Yes, thank you very much. I'm very grateful, as I'm sure we all are, to the organisers. This has been a fantastic opportunity to catch up with a lot of people who have meant a lot to me over the years. So thank you very much. I thought I'd take the opportunity to take a look back at the evolution of my ideas on back pain, and in particular, what role neurosurgery in Bristol has played in my current position. Slide, please. In this book, The Sleepwalkers, Arthur Koestler suggests that, like most scientific advances, those of Copernicus, Kepler and others were largely accidental. They were the result of their personal circumstances and their environment, and their unique contribution to science was more by accident than design. And I think the same principles apply to all of us. We sort of meander through life, responding to and interacting with events, ideas, people and opportunities which take us in actions. Next slide, please. Whether we can accurately recall these events or not is a slightly different matter. Next slide. In my case, I've acquired some rather maverick ideas about back pain. Now, this isn't somewhere I ever intended to be, and it can be rather uncomfortable on occasion. So how did I arrive where I am? Next slide, please. I first encountered neurosurgery at Frenchay, and to me the two terms are almost synonymous, in my first week as a clinical medical student in September 1984, and I had weekly tutorials with Hugh Griffiths. I returned as a medical houseman in 1987, and following house jobs I demonstrated anatomy for a year, and then I just had to go to Australia to realise my lifetime ambition and learn to surf. When I returned from Australia, I had been persuaded that ENT was the perfect career choice for me, but first I had to complete 6 months as a neurosurgical SHO. Slide, please. In those days, we still had a firm structure, and I worked for Mr. Griffiths. We did a single ward round every morning, and as always in medicine, there were humorous events and tragic events. But on one ward round, I remember Martin McGee Collett, who was one of our Australian SRs, asked a patient who'd undergone surgery for an acoustic neuroma if he could please show us his teeth, to which he said, "They're in the cupboard." Another patient had undergone surgery for a growth hormone secreting adenoma. I can't remember who the SR was, but he said, "Don't worry, everything will get back to normal size within a few months." And the guy said, "What? Everything?" Anyway, I had to report back to Mr. Griffiths every day. And one day I went into his office and it was full of the latest batch of medical students. And Mr. Griffiths was telling them on their second day of clinical medicine how to take a history and perform an examination on the phone, something which it took COVID for the rest of the world to catch up with. And one day it came up in conversation that I'd been surfing in Australia for a year, and he said, "What a great thing to do, you should be a neurosurgeon." And I was taken aback and I thought to myself, well, I'm not sure I want to work all hours forever. Anyway, with that comment, he was the first person in authority in surgery who ever had been positive about my slightly wayward career progress, which up until that point had felt like a bit of a millstone. And in both deed and word, he demonstrated that challenging medical dogma was okay and even important. He and others in the department at that time planted a seed in my mind that perhaps I should try and be a neurosurgeon. So I went off to do 6 months of ENT and realised it wasn't quite for me, and I decided that actually where I did fit in most and where my interest lay was neurosurgery. So whilst doing 2 years of, next slide please. While doing 2 years of general surgery in Exeter, I started talking to Rick about the possibility of doing a higher degree. And Rick had become interested in the potential of near-infrared spectroscopy to monitor cerebral metabolism. There were already publications on how useful this technology was for monitoring people with reduced consciousness, and money was being made from sales of machines and expensive disposables. I was awarded 3 years of funding by the Stroke Association. When a prototype machine from Johnson & Johnson finally arrived, there was no way of attaching the sensor to a person's scalp. I spent a lot of time with Nick Kane, who became guinea pig in chief for many subsequent experiments. I used a crepe bandage to attach the sensor to his scalp, and it was immediately obvious that a very small change in pressure applied to the sensor created a fairly major change in the signals recorded by the monitor. In other words, it seemed overwhelmingly likely that these machines were measuring signal changes within the scalp rather than the brain. This meant my grant application and project proposals were based on an unfounded assumption that the technology was proven. We had to rethink the whole project and ended up subjecting members of the neurosurgical department to various physiological insults, the most notorious of which was being rendered hypoxic by rebreathing with carbon dioxide taken out of the circuit, and rumour had it that the neurosurgeons were flatlining. Next slide, please. I would regularly meet up with Rick. I would explain that I'd read papers and expressed incredulity at how imprecise or potentially dishonest many publications were. Abstracts often made claims or draw conclusions that were not justified by the content of the paper, and papers would regularly quote references in support of a particular argument, but on reading the particular reference, it was not uncommon for me to find that it did not actually support the claim which was being made. Rick was constantly telling me I had to be cynical, and one couldn't be too cynical. So as usual, I did as I was instructed, and I became very cynical. It even got to the stage where I started to ask myself why Rick was telling me to be cynical. Anyway, after my research period, I started as a clinical registrar, and I started with Steve Gill, and as you know, he perpetuated the idea that you have to question everything, and of course he's got very many accolades. One thing I remember, which was very unorthodox, and I don't know if this is unreliable memoirs or not, is I seem to remember that at least I went through a period of thinking that surgery was expedited by starting the operation in the anaesthetic room, and the patient would be wheeled into the operating theatre with a bleeding wound. I progressed through the rotation, which included being subject to all sorts of other heresies from all sorts of places. And in particular, I have fond memories of Dr. Brown's enthusiasm for his particular unorthodox ideas in microbiology. But during that time, I decided that I really wanted to live in Devon, where I'd grown up, and that meant trying to get a job in Plymouth. But I felt like I needed some extra training in spinal surgery. That's the next slide, please. And again, I ended up being the first neurosurgeon to complete the National Orthopaedic Spinal Fellowship in Nottingham, and this changed the trajectory of my career in many ways. Clinics in Nottingham were full of patients who'd had lots of injections, followed by fusions or possibly disc replacements, but most of them seemed to end up back in the clinic, still complaining of back pain and generally very unhappy. And I decided that that was an area of practice I was going to steer clear of. Next slide, please. I was very fortunate to be appointed as a consultant in Plymouth, but being the only surgeon, orthopaedic or neurosurgical, with a major spinal interest, I did have some drawbacks. It became impossible for me to avoid the issue of back pain. It seemed a strange paradox to me that one of the most effective operations for relieving pain I had ever observed was a microdiscectomy. and yet other interventions for spine-related pain appeared to be much more of a lottery. And then one day I had an heretical thought. Next slide, please. Could it be that outcomes were poor because we were treating people without a diagnosis? Now, it doesn't sound heretical, but it is, because it implies that, for example, national guidelines on the management of non-specific low back pain without a diagnosis, is fundamentally wrong. So, next slide, please. My current position is I believe you cannot effectively treat someone without a diagnosis. In my opinion, 40 to 50% of the people I see their pain is unexplained by any structural abnormality. And unexplained back pain, in my view, is no different to any other unexplained symptom. The diagnosis for these people is likely to lie in a much more difficult and abstract domain, by which I mean mood-related conditions such as anxiety, depression, and stress. Next slide, please. I've re-examined pretty much everything I've ever been told or read about the causes, investigation, and management of back pain. In my view, the current management of back pain is based on ideas propagated by textbooks, which are based on supposition and dogma rather than evidence, and which largely predates the MRI era. For example, I believe that dural compression can cause back pain and is treatable with decompression. I don't really know what people mean by mechanical back pain. I don't ascribe any significance to leg or back dominant pain. I don't believe there's any evidence that any spinal injections have any significant benefit. And there are others, but you get the general idea. Next slide, please. So the fundamental principles inculcated into me during my time in neurosurgery in Bristol are very much alive and kicking. And I'm now involved in this publication, which aims to promote critical thinking and challenges to medical dogma. So if any of you would like to share your unorthodox ideas and submit an article, please consider contacting me. Thank you very much.